Hello. Hi, everyone. Hello, everyone. Happy Saturday. Lovely to have you all here. And I'm going to invite Dr. Gersh. We're going to have this lovely talk, and I can't wait. If you have any questions, do not hesitate to drop in the comment, or you can even write it in the question bubble. So we're talking all about women's health, menopause, perimenopause, hormones. So it's important to thrive and not just to survive menopause. So that's what is my motto every day. I say it to everyone, and let me just go to invite. Love. Hello. Hi.
So good to see you.
Great to see you. Amazing. Thanks for accepting the invite. It's a pleasure to have you here today with us.
I'm thrilled on this wonderful Saturday to join you to talk about, of course, one of my favorite topics, perimenopause, name it.
It's lovely. Great to have you. I always say about the HRT or hormone replacement therapy that is for too long. It's been narrowly seen as a treatment of hot flashes and night sweats. I think I invite everyone to look beyond symptom relief and recognize HRT as a true longevity elixir. I don't know, what are your thoughts about this?
Well, I certainly see it in that light. And I'm sad to say, just this morning, I was listening to a video recording of a woman doctor who's the head person at a very famous clinic in their cardiac division for women's cardiac health. And she was saying the exact opposite. So it drives me crazy. She was saying this is only for short use, only for women. It's like I felt like I was transported back to 2002. It was like, what is like only the shortest amount of time, the smallest dose, and it's not for cardiovascular health, it's not for brain health, it's just to suppress the very worst of the worst night sweats and hot flashes. And she gave all the litany of issues that were raised from the Women's Health Initiative and didn't question a single one, and just kept talking about hormone therapy, and also obviously referring to what was used in the Women's Health Initiative, the conjugated equine estrogen and the progesterone acetate. And it's just driving me crazy that here we have supposedly authoritative doctors from major clinics, respected in every which way, and this is what they're spouting. So how can women in the community, how can even doctors who are community doctors know what to do when the so-called leadership is actually spewing this really misinformation? It's driving me crazy. So at least we can tell the truth to women who are willing and open to the ideas. And I keep saying the groundswell of interest in hormones, longevity, it's not coming from the top down, except for very few like special situations. Mostly it's coming from the ground up. It's coming of us in the healthcare arena and a lot of women who are living their lives trying to do better with getting their health in order and living with the consequences of hormonal insufficiencies and deficiencies, which are inevitable with the loss of the ovarian function. And they don't want to put up with it anymore. It's like, no, not for me. So, yeah, hormones are not, I always say, hormones are necessary, but not sufficient. There are plenty of 25 and 30-year-old women today who have functioning ovaries who are obese, metabolically unhealthy, infertility, terrible periods, and all kinds of problems. So having healthy or reasonably healthy functional ovaries is not enough. Even when you're young and when you're older, just getting hormones isn't enough. But that's where you start. And then you add in all the lifestyle elements, everything with diet and fitness and sleep and stress control, toxicant avoidance, everything that you can to be optimally healthy along with the hormones. But nothing works right without those hormones. The hormones are the information delivery system. So it's like trying to make a complex recipe, having all the ingredients, all the cooking tools, and you don't even know what the recipe is supposed to be. You don't know what the dish is, but you have ingredients, it's all there. But what are you going to make? What protein are you going to make? What enzyme are you going to make? How are you going to work with your mitochondria if you don't have the hormones? The answer is nothing's going to work right.
Yes, absolutely. I totally 100% agree. So, and again, we see, you mentioned about hormone disruptors and all the environment toxin, and how we see women earlier age of puberty. It's like in their 8 years, 9-year-old kids have their puberty, or younger age menopause. I think that again, mainly is due to these hormone disruptors.
Well, one of my areas of expertise is also not just menopause, perimenopause, but all the spectrum of the decades of life that women have from 12 up. That's predominantly where I begin. Very rarely, although now, like you said, you could be 9 years old and going through puberty, so be earlier. But one of the most common, in fact, the most common endocrine disorder of reproductive aged women is polycystic ovary syndrome. And now we know, yes, there is definitely a genetic predisposition, but it's so rampant now. It's like an epidemic worldwide, every continent that has women suffering from a big percentage of the population with PCOS. And we know that endocrine disruptors that they're exposed to them when they're in utero, when they're a fetus, when the endocrine system is actually developing, is changing it so that it's not working right from the day they're born, which is like so painful to think. They have data showing that the estrogen receptors in women with PCOS, like, they're not receiving properly, they're not working properly. And it's not just estrogen receptors, testosterone receptors, melatonin receptors. So it's more complicated than just estrogen receptors. And they also have that problem on top of all the other problems. And then they've also shown that women who have PCOS, if they test their levels, they tend to have higher levels of BPA, bisphenol A, which is an endocrine disruptor for estrogen, testosterone, and melatonin. It's like really a terrible endocrine disruptor, which is everywhere. And at some point, often much of their lives, they have some degree in them. And women with PCOS may have some more, we'll say, decreased ability to get rid of the BPA. Maybe their detoxification pathways, the women with severe cases, may not be as good. So they're harboring extra amounts of these endocrine disruptors, unlike the one that's most studied is BPA, but we're filled with so many different endocrine disruptors. And they interfere with the very function, structure, production, distribution, elimination, receptor function, everything of these critically important hormones. Of course, I think of estradiol as the pinnacle, but all the others are working in this chemical soup and we're trying to survive. And that's why one of the main reasons why fertility is so declining. And we have so many fertility centers because women are having so much trouble conceiving. And then men too. I mean, just throwing in a little for poor men, that they're really been decimated. I can't believe the decline just in my career during the time that I've been a doctor. It went from normal is like 60 million down to, well, 20 million is okay. So it's like, wait a minute, the numbers are really declining. And so testosterone levels are dropping in young reproductive age men. So yes, I mean, we all should be environmentalists, 100%, because this is really decimating our children, our reproductive function. And of course, in menopause, it's only exacerbating everything that's already problematic.
Exactly. Yes. So for our viewers here, I mean, I assume everyone by now should know about the definition of menopause and perimenopause. But once again, in case someone doesn't know, would love to hear it from you.
Well, it's arbitrary, but it's officially defined as menopause being when you've gone 12 consecutive months without any vaginal bleeding. Now, they could have said it's 10 months. They could have said it's 14 months. It's arbitrary. And of course, that's based on the uterus. But really, menopause is really about your ovaries. The uterus is a target of the hormones, as is every other single structure in your body. And it's easy to look at periods, but that's really not the only, certainly not even the best measure of what's happening involving your ovaries. And that's why talking about menopause and the official definition of menopause will lead many doctors and women sort of astray, because they don't realize, but now it's becoming a little bit more prevalent in the media and in journals, that the issue is really about ovarian decline or senescence, aging of the ovaries, and the production of what I call the vital life hormones, estradiol and progesterone. And testosterone is important too, but it's not a specific menopausal hormone, although it's made by the ovaries, but it's also made by the adrenal glands and in fat tissue from conversion of androgens from predominantly the adrenal. But so we won't get into testosterone for this one, but we'll talk about that another time. But estradiol and progesterone are not going to be made the same amounts and the same rhythm, so on, as you are transitioning into that menopausal phase of life, which can be half of your life post-menopause after that final period plus 12 months. So we know now that during the preceding decade and just escalating in the preceding 5 years before that official period, things are really changing in the body, some of which is obvious, we call that like overt, and some of which is hidden or silent, covert. So you're losing a lot of collagen, you're losing bone, you're losing cartilage in your joints. So things are really aging. Your arteries are changing. They're finding that you make less nitric oxide. Your vascular system is deteriorating. They're getting stiffer. The lining of the arteries are getting unhealthy. Plaque is developing. There are changes in the white matter in the brain. The brain is changing, and women often have word finding problems, particularly nouns. They can remember their adjectives, but they can't remember the name of it. Nouns go. So there are real changes. We find that a tremendous amount of bone loss happens in the preceding 5 years before that final period. So we have to stop thinking about menopause as just about periods, but really about loss of hormone production that precedes that final period. And of course, if a woman had had a hysterectomy, I've had this happen many times, a woman who had a hysterectomy say, does that mean I don't go through menopause? Of course, it doesn't mean that, because you have ovaries and they will be aging, but it's a little bit less obvious. But it's important to know that even in the 20% of women who don't have any obvious symptoms, they don't have night sweats, they don't have hot flashes, that doesn't mean that bad things aren't happening that they're not aware of. In general, the fewer symptoms you have, the better off you are. So I really applaud women when they are lucky enough, or maybe they've had a better lifestyle. In fact, we know that women who are obese tend to have worse hot flashes and night sweats. Women who are inflamed, more hot flashes and night sweats. But it doesn't mean that things aren't going awry. That's why this whole notion that if you don't have night sweats or hot flashes, or they're tolerable, that you shouldn't go on hormones, because less severe or less rapid. But all the things I mentioned are going to happen to you. It's a question of how much and what's the steep decline. Is it going to be a steep, rapid decline, a more gradual decline? But if your goal is healthy longevity, then there is no reason why you wouldn't be on hormones. It's just a really important part of being healthy. It's almost like crazy when you think about it. Like, if for any reason you had to have your thyroid gland removed, like say you had this giant goiter because you never had iodine in your life and you lived in, like Missouri or something, not near the ocean, and you just had this large thyroid gland and you had to have it removed because you couldn't swallow because it was so big. Okay, nobody would say, well, you don't have a thyroid gland and now you don't, so we'll give you more caffeine or we'll give you sleeping or we'll have you take up meditation. That's like not the solution to not having thyroid hormone. If you don't have estradiol and progesterone, the solution isn't to go on, an SSRI. It's not to go on gabapentin. It's not to go on drugs that can work with your hypothalamus to reduce night sweats, directly, but not have any other benefits. The solution is to give the hormone that you're deficient in. I mean, it's like so simple to think of it that way. You don't have a hormone, you give a hormone. If you don't have enough of it, you give it till you get to the right amount. If you don't have any, you still give it to the right amount, right? It's just, and what's the right amount? The right amount is the best amount, the optimal amount. What's that amount? The amount that you would have when you're optimally healthy, like when you're about 25. So, we don't want to have the esteemed level of a 50-year-old when you're 60. You want the level of a 25-year-old when you're 60, or 25-year-old when you're 50, because you just want to have the healthiest level, to have the healthiest body, so that your cells in your body will do the optimal thing. Your mitochondria will keep making energy, controlling the cell cycle. Liver will have proper detoxification. You won't have ectopic fat deposits. You won't lose all your bone. You won't get osteoporotic fractures. You will reduce your risk of dementia and heart attacks and strokes. I mean, can we prove everything I just said? We actually can't, because we don't have the clinical studies, but we do have the science. And this is sort of a no-brainer. We know that when you lose your hormones, all these bad things happen. And the earlier you lose them, the worse they are and the faster they happen. So how can it be that if you don't have the hormones and you lose them earlier, like early menopause, things are worse? How can it be that all these things happen when you don't have hormones, but the solution cannot be that you replenish the hormones? How is that logical? And we know that every organization recommends, if you go into menopause at age 40, that you go on hormones to age 50, but not beyond necessarily. That doesn't make any sense. If you go into menopause at age 50, why is that okay, but not okay if you go into at age 40? The clock starts ticking in terms of degradation of all your organ systems when you lose your hormones. And why would we want to celebrate losing hormones at any age? If you're lucky enough to go into menopause at, that doesn't mean you shouldn't go on hormones at 55, or 10 years earlier when you were perimenopausal, right? So that's what I'm doing. I'm starting women years before, when I know they're in transitional state.
Great. That's lovely to know. So you mentioned a little bit, but what is the most the most common misconception you hear both from patients and practitioners about hormones or hormone replacement therapy?
It still is, hormones will give you breast cancer.
Mm-hmm.
Yeah. Now we actually have data. It's not just science. We do have science too, which I'll touch on, but we even have clinical studies that have looked at that. There's like at least 12 studies that show that estrogen is at worst neutral, neutral to breast cancer, and at best it reduces breast cancer. And I think that's really where it's at, that hormones reduce the risk of breast cancer. They don't give you breast cancer. And if you look statistically, what demographic has the most breast cancer? It's non-hormonalized postmenopausal women. And the biggest risk factor in the menopause to getting breast cancer is actually obesity, which creates and is also the result of metabolic dysfunction and inflammation, because inflammation underlies pretty much every single thing that goes wrong, including cancer. And cancer now is recognized to be a metabolic disease. So it means that when you have obesity, malnourishment, sedentary lifestyle, systemic levels of inflammation, gut dysbiosis, leaky gut, all those things are in the risk of breast cancer. And all those things increase in menopausal women who aren't on any hormones. So But if you look at estradiol, if we just take, and then we can even look at progesterone. Estradiol, what does estradiol do that it can lower your risk of breast cancer, not increase it? Estradiol regulates the mitochondria, which control what's called the cell cycle. So there are these cells in our body, like almost all cells, they get old and old and older. And that's what we call senescence, the aging of the cells. And cells can get very old and then they're not very functional. They're like just old, decrepit cells. We call them senescent cells. And sometimes they should just kill themselves. They always at some point need to just die, get rid of them. And that's triggered by mitochondria. The mitochondria tell cells, now please die, okay? Get rid of yourselves. You're creating inflammation, and those cells can have what they call misfolded proteins, turn into cancer. And if they don't die and they just keep lingering in the body, some people have named them zombie cells because they're very harmful cells. They don't do anything useful. They just create inflammation and can turn into cancer. And estradiol is the modulator, the regulator of the mitochondria to keep the mitochondria healthy and functional so that they continue to control the cell cycle and make those zombie, yucky, senescent cells die. And that is really important. The other thing is estradiol modulates the immune system. And when you have estradiol, it controls when inflammation turns on and when it turns off. And in the normal state of things, if you're not being invaded by a lot of pathogens, bacteria, and viruses, you're not injured, you're not in a trauma accident or something, then you should be in the homeostatic state of not being inflamed. You shouldn't have inflammation activated in terms of the autonomic nervous system, which estradiol modulates and controls. Should be more vagal tone. The vagus nerve should be the dominant, not the sympathetic or the stress state. And that keeps inflammation at bay. Well, when you don't have enough estradiol, you don't have control of your immune system and your autonomic nervous system, and you become more inflamed. And then you have inflammation running amok, and inflammation underlies dysregulation of cell function, cancer. Inflammation in the breast is a terrible thing. And then you end up having, abnormal cells, DNA breakage, and cancer. And what else does estradiol do? It actually maintains the integrity of the cells so that they don't, like, if you have cancer, that's why women who do get breast cancer, because anybody could get breast cancer on or not on hormones, but if you do get breast cancer and you're on hormone therapy, you have a better prognosis because maintains the cohesiveness of the tumor. So that, because what kills people isn't cancer in the breast, it's cancer that metastasizes and goes to your lungs and your liver and your brain and such. But if the cells don't break off, if they're held together like super glue, then the breast cancer can grow and grow and get bigger, but it doesn't metastasize. But if it's without estradiol, the cells become more like held together by spit, and they just go flying off, and they'll get in your lymphatics and your blood, and they'll spread throughout the body and could kill you. So estradiol maintains that. The other thing, and it's partly related to the inflammation control, when you have a lot of inflammation in the body, when you don't have enough estradiol, and estradiol also maintains the gut microbiome, so you don't get leaky gut and have systemic inflammation from dysbiosis or abnormal microbial population in your gut, then what happens is when you have all this inflammation, it upregulates an enzyme called aromatase. And aromatase is in all of our fat tissue and other tissues, and it becomes activated because that's part of the body's response to inflammation. But now it's like being used inappropriately, okay? And now you have upregulation of the enzyme aromatase in the breast tissue, in the stroma, the connective tissue, and the fat. And this causes the conversion of androgens, mostly from the adrenal gland, like they're called DHEA, DHAS, into estrone, not estradiol, the ovary, but this other estrogen, which predominantly works on the receptor that creates inflammation. And that's the receptor, the alpha, that's on breast cancer. So now you have the perfect storm because you don't have enough estradiol. You have the breast tissue making its own estrogen supply, but not the right kind. It's making the wrong kind. It's making estrone, which is creating more growth factors or proliferation. And then if you, because of the inflammation, not because of the estrogen, but because of the inflammation and the lack of cell cycle control, you end up getting damaged DNA and you get a cancer that develops in the breast. You now have the breast creating its own estrone. This is not hormone replacement therapy. This is the breast making its own estrone that actually creates growth factors in the breast cancer that can then grow the breast cancer locally in the breast, which is being supported by the estrone produced in the breast stroma and fat tissue that's initiated by inflammation, which then is augmented or exacerbated by the breast cancer, which is very pro-inflammatory and creates even more inflammation, creating even more of this bad type of estrogen that has nothing to do with hormone replacement therapy. But people get it all mixed up. They don't understand that it's a different type of estrogen. It's being made inappropriately. It's all inflammation and cancer then related. But if you have enough estradiol to begin with, plus all the good lifestyle things, it will keep inflammation down, will prevent the damage to the DNA, to prevent the breast cancer in the first place, and will keep the cells cohesive, and then you will have less chance of getting breast cancer at all. So, but people are so confused, and all they hear is estrogen, breast cancer, estrogen, breast cancer. And I just want people to understand that taking hormone therapy, especially the sooner the better, to maintain a continuum of hormones at good levels and rhythms throughout the body from perimenopause on through the rest of life, will lower the risk of all that bad stuff I just described even happening. But of course, you need to add in, avoidance of endocrine disruptors, because those chemical endocrine disruptors are very associated with dysregulation of everything. So, and promoting more breast cancer and other cancers as well. So we should love our estradiol. We should love is also very anti-inflammatory and also is anti-breast cancer when it's real progesterone, not a fake mimic like what was in the medroxyprogesterone acetate component that was used in the Women's Health Initiative, so-called hormone therapy. And that is a different chemical that actually is a progesterone endocrine disruptor and has a negative effect, not a positive effect, on the immune system and breast health. So we just can't mix these words and think they're all meaning the same thing. So when you hear people talk about hormone therapy or menopausal hormone therapy, you have to say, and they talk about a study, it's like, well, what did they actually use? And what were the doses? Because, the detail is really important. What they used, how they used it, the dose they used, all those things matter. So you can't just say hormones do this. Like, what hormones? What are you talking about? You have to be really specific, because otherwise people are so confused because they don't know. When people say a hormone study, what hormones? What did you do? And this is where even people in academic positions, in high-level academic positions, they use words. I've seen articles in high-end journals use the word progesterone when it meant progestin. Exactly. It was a progesterone, and yet in the article itself, it referred to that fake hormone for progesterone, a progestin, as progesterone multiple times. And these are in like the top journals and by, esteemed researchers. So the words are used wrong all the time. We have to use the words correctly. We have to look at the detail and then understand the mechanisms so that we don't get confused and do things inadvertently that actually are against our best interests, like not going on bioidentical hormones.
Exactly. So now that we know that these lovely hormones, estrogen and progesterone, are anti-inflammatory and they're good for us, but then, like one of the patients who saw me a few days ago said, I love to go on and start HRT, Dr. Amin, but my grandma had breast cancer and I can't start it. So what are your answer, or what's your answer to these patients who are now worried about the family history of breast cancer?
Once you understand that bioidentical hormones don't increase the risk of breast cancer, if you have a family history, then you want to look at, well, what was the story? Is there a gene that should be tested? Should you have genetic testing? Sometimes that is the appropriate thing to do, because there are genetics that can increase your risk, which is not the same as saying the hormones, genetics, okay? Then you want to say, well, where did she grow up? What was she obese? Did she have diabetes? Did she have other problems? You know, what is about her situation? Was she premenopausal, postmenopausal? But the bottom line is that bioidentical hormones are not cancer producing. They're actually cancer preventing, but reducing. Nothing, you can overcome the best thing and still get cancer, so, but like one of the things that just is shocking to me, but it doesn't get talked about, but I'll just mention it, is that there's published data, and nobody seems to care about this, that oral contraceptives and hormonal IUDs increase the risk of breast cancer, not dramatically, but it's statistically significant. And yet nobody seems to care about that. We talked about endocrine disruptors, eating a lot of ultra processed food, being sedentary. There's so many things that increase the risk of breast cancer that I'll call it the low-lying fruit, things that are ignored. Those are the things that people should be focusing on, like how long were you on this kind of contraception? Is there another option you can use that is going to help prevent pregnancy? We don't want unwanted pregnancies, but is there something else you could do at this stage of your life that is going to not involve hormonal manipulation with essentially what are chemical endocrine disruptors, because that's what all these hormonal contraceptives are. They are what they are. They prevent pregnancies, 2 thumbs up for that, but they are endocrine disruptors, 2 thumbs down for that. So we have to look at your options. Is there another viable option or not? And then look at all the other lifestyle issues. Are you eating the right foods? We know that eating cruciferous vegetables like broccoli, cauliflower, Brussels sprouts, kale, arugula, these are anti-cancer. Having adequate antioxidants by having adequate minerals and vitamins are anti-cancer. Being fit, exercise dramatically can being fit lowers the risk of breast cancer. The taking hormones, bioidentical hormones, is not the cause of breast cancer, but there are many other factors that can come into play, and multiple factors. That's what we should be focusing and looking at, and recognizing that bioidentical hormones, regardless of your family history, are still going to do the same good things in your body. But if you do have a family history, then you really need to look at the genetics, if that's indicated, and all the other things that come into play, like when you have a family cluster of cancers, like they did this when, if you ever saw the old movie Erin Brockovich, there were these clusters of cancers in a community, and it wasn't because they were on hormones. It was because there was poison in the water supply. There was like heavy metal that was polluting the water supply. So you have to look at what is going on. Is there clean water? What's in the soil, what's in your air. We know air pollution is very toxic to the immune system. So, look at what you can control and then see what you can do. Or air and water purifiers, eating organic whole foods, exercising, working on sleep. Inadequate sleep is a huge contributor to breast cancer, because there's a wonderful thing that happens in the body when you're sleeping with your immune system and clearing out yucky cells and rejuvenation. So I don't want people to think at the end of our little show here that going on hormones appropriate bioidentical hormones will increase their risk of breast cancer. It will not, and likely it will reduce it, but it doesn't eliminate the risk. For that to lower the risk, you got to do all the things you can control. You can't go back and control what you were exposed to in utero, in your childhood. You can't change the past. You can learn from the past, and you can do everything from this point forward to be optimally healthy, to optimize your gut health, your detoxification pathways, and your sleep, your stress, your fitness status, your happiness and purpose in life. Doing all you can control will lower your risk, not just of breast cancer, but of heart disease, other cancers, and and so on. So there's much we can control, but there's too much emphasis on the wrong things and not enough the right things that we can do to lower risk for cancers and all the other diseases that often take our lives prematurely.
That's lovely. And certainly, so we know that benefits are outweigh risks. And so this lady who's a perimenopause and wants to start and be on an optimal levels of hormone, replace the hormone that she has lost now in perimenopause. How do we measure? What's the way to measure, if any? Do you run any tests?
Well, in perimenopausal women, I'll often do menstrual mapping tests. They're done through urine collections, and that is looking at metabolites, but it was a very good reflection of blood levels, serum levels. And for women who are now stopped making hormones, I do monitor the hormone levels that I give, my prescriptive hormone doses. I do measure their blood levels. I get blood tests, and I look at the levels that I'm achieving. I'm looking to get levels that are similar to what average levels would be in healthy women. I'm not trying to absolutely replicate at this point. That could change, because we don't really know how to, absolutely replicate an exact menstrual cycle. But we do know that you want to have levels, like for bone, we know that an estradiol level of about 100 picograms per mil will actually help to grow bone. So if any level under 50 is not going to be adequate, even a little bit, to support vaginal and bladder health. So I do like to look at also to help people feel. It's always a combination of levels and personal, feelings and desires and responses. So we want to look at estradiol levels. And then for progesterone, I've now gone on a little campaign to try to get women and practitioners to prescribe progesterone intravaginally rather than orally, because when you give it intravaginally, you actually don't go through that first pass through the liver by taking it orally, which converts 80 to 90% of it into other stuff called metabolites, which are good, but too much of a good thing is a bad thing. So you get this big bolus, it's not physiologic, and you get very tiny levels of progesterone in the blood because most of it's converted into other stuff. But you don't get any of that problem with vaginal progesterone. You get good effect on the uterine lining, and you get good blood levels. But I know I'm an outlier still on that. Most doctors are recommending oral, but I no longer believe that that's an optimal way to do it. But it's out there. And so, but I do measure progesterone. I never used to. I measure progesterone, and I want to get good levels commensurate with what a woman would have when she had natural production of progesterone during a natural menstrual cycle. Because we do know that progesterone does a whole lot of good stuff in the body. And like everything I mentioned, dose matters. Everything is dose related. So I want to get a dose in that's going to do the things I want to have done in the body. So that's why I say measure levels. I give hormones that are bioidentical, and the estradiol is always estradiol. It's always through the skin, whether it's a patch, a gel, or a cream. It's always through the skin. And I prefer now, like I said, progesterone intravaginally. And but everything is to what a woman is willing to do. I'm always flexible. I never dictate. Everybody has to have their own decision-making algorithms that works for them. So I present what I think is best, and then I give them choices, and everyone chooses because everyone has their own decisions to make and priorities. and preferences. And we women, we can change our mind. We can start with one thing and we can change to another. Like it's a start with a patch. You don't like it, we'll switch to a gel. You don't like it, we'll switch to a cream. So everything, we have to be open-minded and change as new information comes forward, right? We don't want to get and think that what we do is always right, because maybe it isn't. Maybe we need to change. So you have to be flexible in this world as new information is forthcoming.
Yes, very well said. And a lot of my patients, or I hear, take oral progesterone because it helps with that GABA effect and sleep. I'm not sure if that will be if they use it transvaginally.
Well,
Like,
when progesterone will convert naturally through the action in the brain and elsewhere in the liver, the action of the enzyme 5-alpha reductase will convert some progesterone to the metabolite allopregnanolone. But
yeah.
progesterone itself has major benefits. It also works in the brain on the neurons. It increases myelin. It's anti-inflammatory. It works on the bone. So we don't want to not have enough progesterone. The problem is when you take it orally, you get too much allopregnanolone, which is very good, but too much is just too much. You get too much allopregnanolone and you don't get enough actual progesterone. So the only way to get around that oral conversion in the liver conversion factory is by not having it go through your mouth and then into your liver. You have to use it. I didn't mention this. You can use it as a cream, but we have no good data showing levels. So you have to really watch it if you give creams. And you can actually take a progesterone tablet and put it in the rectum, which sounds icky, but I'm telling you, I have some patients that love that because they get used to it and they just poke it in there and then they go to bed and there's never any discharge because the anal sphincter keeps it tight in, and they've published data showing really, really good progesterone blood levels. Progesterone will travel through the blood, it will travel to the brain, it will be converted into allopregnanolone appropriately. So you're not doing like a drug dose. So once again, too much of a good thing is a bad thing. Too much allopregnanolone is just too much GABA. I mean, GABA is good, but too much GABA is too much sedation, and it can affect memory creation. We don't want to impact. It's not exactly the same mechanism, but they both increase GABA. And that would be like taking tranquilizers or sleeping pills. We don't want to take that because that can affect, like you wouldn't do that and drive. Alcohol is a depressant. You don't want to take downers. So allopregnanolone is like a downer. It's like, it has a lot of good benefits, but too much is too sedating. So, allopregnanolone as a drug, it is a drug. In a synthetic form, it's used for postpartum depression. It's a Schedule 4 controlled substance. It has all the warnings like Ambien and Xanax and Valium. It's a controlled substance, which you have to do like specialized prescriptions. It's controlled by the DEA, and it's a controlled substance. But we're giving it through the conversion from progesterone in the liver, but nobody's talking about it as a controlled substance, that it's too sedating. And a lot of women do feel it, not all, but they feel a little bit drugged. They feel a little bit like, whoa, like I feel like I just took a sleeping pill. You kind of did. But I'm all for allopregnanolone. I love allopregnanolone, but not in a giant bolus coming out from your liver. And I want to have enough progesterone. So I started measuring levels. Ask your doctor to measure your blood level if you're on oral progesterone. I'm telling you, you're going to get a level like 1, 2, 3, 4, if maybe at the most, if you're on 200, rarely higher than that. And that's what's also in the published literature. You need a level over 10, preferably over 15, to actually do all the things you want progesterone to do. So, and then a lot of times women have sleep problems because they're not on enough estrogen. The estradiol increases serotonin production when you have enough estradiol. And from serotonin, which is the feel-good, happy hormone neurotransmitter, comes melatonin that helps you to sleep. So if you don't have enough estradiol, you're not going to have enough melatonin. Also, if you have gut dysbiosis, you make a ton of serotonin and melatonin in your gut. That's not going to be made properly either. So you got to look at why are you having sleeping problems. And if you think the answer is high doses of progesterone every night, that's no different, I hate to say it, than taking a sleeping pill every night. which is not good for your brain long term. When root cause medicine is, let's find out why you're not sleeping and address the root cause instead of drugging you, essentially using progesterone as a drug to put you to sleep. That's not what it's for.
Mm-hmm. Amazing. Great. You often talk about the importance of rhythm in HRT for women. So I would love you to talk a little bit about the cyclical versus static hormone therapy in women.
No, don't kill the messenger, but women have rhythms. There's circadian rhythm, that's the 24-hour rhythm, and then there are infradian rhythms. And those are rhythms that are longer than 24 hours. The most famous is the lunar rhythm of the menstrual cycle. And there's method in that madness of the menstrual cycle. When you have progesterone on and off, it turns on and off receptors and genes. It upregulates, downregulates. So like progesterone downregulates testosterone receptor function, estrogen receptor function. Estrogen upregulates its own receptor function, progesterone, thyroid, testosterone receptor function. And these rhythms like reboot the receptors. When progesterone is stopped, it's like a reboot to all the receptors. It's like now, like you turn on and off to reboot, like if your computer isn't working right, reboot. Okay, so that's what happens when the progesterone stops and you turn on and off genes. So you have tumor suppressor genes that turn on and off, and they're related to rhythm and levels. So it's not, it just is what it is. And here's the, if you want enough estradiol to actually create growth factors like brain-derived neurotrophic factor, nerve growth factor, these are vital like for having proper neuronal health in your brain, but to grow bone, like vascular endothelial growth factor, to grow new blood vessels, and so on, to heal, to grow, to rejuvenate, to renovate. All of that requires growth factors. Well, unfortunately or fortunately, depending on how you frame it in your mind, if you rejuvenate all these other organs, you're going to rejuvenate your uterus. Duh, it's in your body. I can't keep them out of your uterus. And rejuvenating the uterus means rejuvenating the lining, the endometrium. So it will grow. Estrogen creates growth factors. Controlled growth factors. Uncontrolled, that's cancer. Controlled is good. That's called life. So you have good controlled growth factors, you're going to proliferate or grow the uterine lining. And here's the thing, if you want to have adequate amounts of estrogen to grow everything else in the body, rejuvenate, replenish, and repair, then you're going to grow the uterine lining. It's a package deal. And if you grow the uterine lining, you have to shed the uterine lining. You can't growing. Where's it going to go? It's going to start becoming unstable, fall out. You have random bleeding. So if you grow it, you must shed it. So that's part of the logic. So you give the progesterone in a cyclic pulsed way. And there is some data, some of it's in mice, some of it's in rats, and some of it's in people, that you have better outcome with cyclic progesterone for brain health, for cardiovascular health, and for immune health. So the bottom line is you have to mimic nature to some degree if you want optimal outcome, just how it is.
Very interesting. I mean, my patients, I do is like a static after menopause. They go on. I mean, perimenopause, I do cyclical, but not postmenopausally.
Trying to change the way of thinking about it. One person or 10 or 20 or 109. But I so appreciate you letting me tell my sort of outlier opinions.
Of course, I love it. I love to hear whatever you're saying. It's just beautiful. It's so insightful. I love so much experience you have, which is great.
Say I've been around a long time. I'm one of the small percentage of doctors who was practicing medicine when the Women's Health Initiatives came out. So I know how people thought about hormones before, and I saw what happened after. And because I had the before, I already had the foundation of understanding hormones that pretty much got lost after the Women's Health Initiative, when education on menopause and hormones completely fell by the wayside. So, I was privileged to actually know about hormones before, and I kept my knowledge after. And, you know, so I'm just trying to bring I should actually talk another time about the history of what was really happening in medical practice.
Yes.
When, like me, I was in practice when the women's health.
Yes.
Now, what I did before and how I dealt with that, that's another whole story. But I really hope that everyone will just, you know, think about what they just, you know, think about the information. I'm still evolving, you're still evolving, we're all still learning, open-minded. And but the first step is to acknowledge there is a problem. Menopause is a problem. It is not a health advantage for women to go
Mhm.
through. It's not if it's a problem, it's how bad a problem it is for each woman, because losing these vital life hormones is not a plus in any woman. And then we have to figure out, and this is still the big, you know, the big void, and the sort of like the future, the horizon, is how to actually give hormones back to women once we all acknowledge hormones are good. Menopause is not a health benefit. How can we give hormones in a practical way that's usable, that isn't going to drive people crazy, that's usable, livable, and efficacious to optimize health for what could be the rest, you know, half of their lives? So we're still on that journey, and I'm on it, you're on it. We're learning, we learn together.
Any thoughts about testosterone? We can't live without having a little word about testosterone.
Okay, so last word, testosterone. Testosterone does not go down at menopause. It turns out you don't need a single egg in an ovary to make testosterone. It is always able, the ovaries can always make testosterone. But like everything, things get less efficient over time. But where does most of the testosterone in the body actually come from? Well, it actually comes directly or indirectly from the adrenal gland.
Mm.
70% of the testosterone of the female comes directly or indirectly through the adrenal gland, and only 25% comes from the ovary. The adrenal gland makes 25% directly, and the other 50%, so 25 from the ovary, 25 directly from the adrenal, the other 50% is primarily, not exclusively, but primarily from adrenal androgens that are converted into testosterone, predominantly in fat tissue. So close to 75% is directly or indirectly from the adrenal gland. The adrenal gland production of testosterone and the other androgens doesn't go down at menopause. It may even go up, because part of menopause is stress, okay, through the nervous system. It's called adrenergic adrenal. So the cortisol from the adrenal gland production goes up due to the stress of menopause and what happens. And the hormone from the pituitary gland, called adrenocorticotropin hormone, ACTH, triggers the adrenal production of cortisol, which goes up. Well, that same hormone from the pituitary gland triggers the adrenal gland to make more androgens, like DHEAS. So androgen production from the adrenal gland, along with cortisol, goes up around menopause. In addition, because you have less estrogen, sex hormone binding globulin, which binds up testosterone very tightly, the production of that binder goes down. So you have more unbound or available testosterone to the tissues. So some women around perimenopause, early menopause, actually show signs of androgen excess. They start having suddenly acne breakouts, facial hair, having to shave, like, what the heck is this? And they start losing their hair, androgenic alopecia. The last thing they need is more testosterone. So this craziness of everyone hits menopause and they're all getting testosterone pellets is insane. Okay, so you need to look at testosterone. Over time, it tends to go down, because the adrenal gland production, the area of the adrenal gland that makes androgens, is called the zona reticularis. Literally, if you do imaging, it shrivels as we age. So androgens do go down with aging, DHEAS and testosterone as a general thing, but it has nothing specific to do with menopause, and it may even go up, especially the testosterone is the precursor to estradiol. And what triggers the ovaries to make testosterone is the pituitary hormone that's triggered by the brain, called LH, luteinizing hormone. And often that will go up, And then the ovaries make more testosterone, but they can't convert it well into estrogen anymore in perimenopause and not at all in menopause. And so they actually have more testosterone coming more from the adrenal gland through the androgens and the testosterone, and they have too much androgen in their body around perimenopause, early menopause. So, don't take and don't throw, if you're a provider, don't throw androgen at women. Measure and look at their symptoms and see how they're doing. They may or may not benefit. I can't say, I can't generalize, but I can certainly generalize and say they don't all need it. Okay? So testosterone and DHEA are vital hormones as well. And I do prescribe them, but I don't prescribe them routinely to anyone. It has to be based on individual levels and needs.
Yeah, that's I agree totally. Like the other day, another patient approached me from another provider saying that I feel tired, exhausted, and no libido whatsoever. My provider has given me estrogen and progesterone, but avoiding giving me testosterone. So she wanted basically to get testosterone from me, but again, I normally do the test, blood test and the urine test, just to make sure what the levels are.
Well, as just a parting thing, I just want to mention the one approved use of testosterone in women is a crazy condition that's made up called hypoactive sexual desire disorder. And that is where women, it's not low libido. It's like you think you should want more sex to be happier, but you don't. I mean, it's like really weird. Like it doesn't matter how often you have sex, you think you'd be happier if you wanted more. But it's not that you have a low sex drive. You just think you should want more sex. It's just weird. But anyway, that is the one condition that's FDA approved for use of testosterone, and it's not based on levels, as long as you're not over the top of the reference range. But I think that's kind of nutty. That's my personal editorial.
Mhm.
And if someone has low libido, the first thing you want to think of is, are they on enough estradiol? Because estradiol
Exactly.
regulates testosterone receptor function, and as well, estradiol is critical for the production of oxytocin, which is very involved in sexual function and sexual desire as well. And then you want to look at all the other things. Women are very complex. Maybe they're having a marital issue or a relationship
Yeah.
issue. Maybe not getting sleep. Maybe they're worried about their aging parents. There's so much that goes into sex drive that isn't testosterone related. So everything that is libido isn't testosterone. So every case has to be looked at independently. I think we're having a connection issue. Anyway, I really appreciate you inviting me on. This has been really fun. I hope we can do it again.
Absolutely. We love to hear all the history about your story from before Women's Health Initiative and after. It's lovely. So hopefully next time.
Hey, I'll share all my memories. I hope I keep them. No, I'm just kidding.
It was great meeting you, and I mean, I've seen you before talking. You are one of my um, one of the instructors in A4M. I remember from 2019 doing all my hormone module with you.
Well, I'm here anytime you want. We'll do another, and I'll invite you on my Instagram too. So,
It was lovely having you here. Great, everyone. Thank you being with us today, and see you soon. Bye
absolutely.
bye. Thanks, Dr. Gersh.